The facial nerve is responsible for supplying the muscles of facial movement, and these are characterized by being attached to at one end to a bony structure and another to the skin. Taking the landmark of the parotid salivary gland, which is here, the nerves branch out from this area. And they are temporal, zygomatic, buccal, marginal mandibular, and cervical. So all of these are what's known as branchial motor branches of the facial nerve and deal with movement of the facial muscles. That's temporal, zygomatic, buccal, marginal mandibular, and cervical. The facial nerve also has some visceral motor branches. These are efferent parasympathetic innervation to the lacrimal glands, submandibular and sublingual salivary glands, as well as the mucous membranes of the nasopharynx. There's a special sensory component which deals with the taste in the anterior 2/3 of the tongue. And finally, a general sensory element goes around to in what's called the posterior auricular nerve, to the auricular area, supplying the muscles around the ear, and the sensitivity around the ear, and also to the occipitalis muscle. Bell's palsy is a disease where the side of one side of the face becomes paralysed due to swelling of the facial nerve. This usually develops over 1 to 3 days and is common in adults in their 40s. The disease slowly improves under its own conditions in 1 to 3 months and eventually disappears. The parotid gland, which, as I said, is crossed by pretty much all the facial nerve branches, is tightly enclosed in fascia, so swelling of it is very painful in the case of mumps. The parotid duct lies on top of the masseter muscle, and actually pierces the buccinator muscle. The masseter is the muscle that comes down like this, and it's involved in chewing, and the buccinator being like this, used to pull the cheek flat. The external carotid artery, which runs up through the gland, divides between the maxillary artery going towards the mouth and the superficial temporal. The layers of the scalp are easy to remember because you can use the same acronym, and that's skin, connective tissue, aponeurosis, specifically the occipitofrontalis aponeurosis. And this accounts for the aponeurosis between the frontalis and occipitalis muscles, which are to do with raising the eyebrows at either end of the skull. Loose connective tissue, and periosteum. The cutaneous innervation of the scalp comes at the front from the supraorbital nerves just above the eye, which pass through the supraorbital foramen. And remember, these are parts of the trigeminal nerve, cranial nerve 5. Also from the trigeminal nerve come the articulotemporal branches, and these are extensions of the mandibular branch of the trigeminal nerve, and follow the course of the superficial temporal artery and vein. The rest comes from the second cervical vertebra via the occipital nerve, with its greater divisions going right up to the top at the back of the head, and the lesser divisions more to the side and not as high up. So it's supraorbital, articulotemporal, or auriculotemporal, greater and lesser occipital. And for the arterial supply, the superficial temporal arteries, the supraorbital arteries, the occipital, and posterior auricular arteries, which come up just behind the ears. There are free anastomoses from side to side, and the vessels run through dense connective tissue in this region. In a condition called Panda's eyes, the loose connective layer of the scalp will allow bacterial fluid to pass freely from the posterior aspect of the scalp into the eyelids at the front. And so if following trauma of the back of the head you notice blood showing up in the eyelids, this indicates that there is a problem going on still at the back.